So next question is, what is the most important message to GPs? I think tick-borne infections are a increasingly recognized condition that have not been in the radar screen of many consultants, many GPs within the European Union. Studies are showing that it's much more common than we were aware of. It is the great imitator, so it's not always that obvious. Not everybody has a positive antibody test. Not everybody remembers a tick. The tick is the size of a sesame seed. Many people will not remember seeing a sesame seed sized black dot on their body, especially if in their scalp or their back. So I think Lyme is a clinical diagnosis, and you should have a high degree of suspicion. We commonly diagnose sinusitis because people have head pain. We have no reservations about putting people on antibiotics for a very soft clinical diagnosis of sinusitis. I think we should have more strict guidance on antibiotic use. But if you have an ECM rash, or you have a history of a tick bite, even without a rash, and you develop symptoms following that, I think that is a red flag. Patients should be considered for treatment for Lyme disease because Lyme is a clinical diagnosis. I think the additional challenge is it is multi-system. So I think if you see somebody who's been to one specialist after another with multi-system symptoms, I think you should consider Lyme disease. The antibody test is not always positive, so the adage that your test is negative, you can't have Lyme is not an appropriate one, and in fact is inaccurate. The Lyme test is 50-50. There's a window period. Some people don't develop an antibody test positive at all. No different than COVID, which is a hot topic presently. 58% of people who had COVID confirmed by PCR 2 months after their COVID infection, their COVID antibody goes negative. Do they not have COVID? Of course they have COVID. Do you depend upon the antibody? No. So no, by analogy, Lyme disease is not dependent upon an antibody test. A negative antibody test can mean you have the infection. A positive antibody test in somebody who's healthy can mean you had a previous infection. So you have to take the relevant history, multi-system disease. You have to listen to what the patient says. Chronic fatigue syndrome, fibromyalgia. Not every patient born sick from the day they were born with chronic fatigue syndrome, with fibromyalgia, are going to have Lyme. But there's lots of people who are previously well, who all of a sudden are hit with this mystery illness, and after years and years, nobody can figure out the diagnosis, and they're then given a diagnosis of chronic fatigue syndrome. How do you diagnose chronic fatigue syndrome? It's a diagnosis of exclusion. All the tests are normal. How do you diagnose fibromyalgia? It's a diagnosis of exclusion. All the tests are normal. So I think you should actually take patients with suspected Lyme seriously. Obviously, you should exclude other diagnoses, but tick-borne infections are much more common than we previously understood. And we talk about the dangers of antibiotic therapy. As stated before, the treatment for Lyme is commonly 3 weeks of doxycycline. In the NHS, treatment for acne often consists of a 6-month course of a doxycycline-like antibiotic. So in the right situation, antibiotics can be life-saving. Doesn't matter if it's cosmetic reasons like acne, but Lyme is much more serious than acne, and you can't use the argument that you can treat people for 6 months for acne, but you can't treat them for more than 3 weeks for these debilitating conditions that Lyme disease causes.